1 minute.
Ladies and gentlemen, thank you for standing by and welcome to the LA County COVID-19 update call. At this time, all participants are in listen-only mode. You may put yourself in queue by pressing 10 at any time. I would now like to turn the conference over to Supervisor Hilda Fleece. Please go ahead.
Good afternoon, everyone, and thank you for joining us at today's press briefing. Today, I'd like to discuss two essentials for our communities, both of which have been challenging to come by for many among us during the COVID-19 pandemic. New research released today by the USC Dornsife Public Exchange, led by Dr. Kayla DeHay, Assistant Professor of Preventive Medicine at USC, provides the first comprehensive analysis of the COVID-19 pandemic's impact on food insecurity in Los Angeles County. The USC team worked in close coordination with our county's Emergency Food Security Branch under a strategic partnership. Food insecurity refers to disruptions in food access and regular eating because of limited money or other resources. It's often associated with hunger, but it also leads to many negative physical and mental health outcomes in children and adults. USC's research identified several important findings. During the first 4 full months of the pandemic, 1 in 4 LA County households experienced food insecurity. That's an estimated 873,000 households. The majority of adults who experience food insecurity anytime between April and July are low income, female, Latino, Black, or 18 through 40 years of age. Major risk factors include having a low household income, being unemployed, and being a single parent. The unprecedented rates of food insecurity created by the pandemic are improving. They peaked in April through May 2020 at 26% and declined to 10% through June to July. However, they remain significantly higher than pre-pandemic levels and are very concerning. Low-income populations and communities of color who are being hardest hit by the pandemic are also those suffering the most from sustained food insecurity. Food insecurity is known to compromise the quality of people's diets, and this research found that people who experienced food insecurity during the pandemic had unhealthy changes to their diet. This is likely to worsen existing food and health disparities. Additionally, high-income households rarely experience food insecurity, but the surge in food insecurity during the pandemic has affected this demographic as well. 1 in 5 households that experienced food insecurity during the pandemic were not low income. However, there's also some good news. The research indicated that food and financial assistance programs appear to help people transition from food insecurity to food security during the pandemic. Many food assistance programs have been launched, adapted, or expanded to address food insecurity during this crisis. For example, the county's Elder Nutrition Program has more than doubled the number of meals it provides per month. CalFresh enrollment has also increased. Importantly, the study found that among households who experienced food insecurity at the beginning of the pandemic, those who were enrolled in CalFresh were more likely to become food secure by July than those who weren't enrolled. We already knew that CalFresh was a critical food safety net for low-income families, and this research shows just how important it is to get households who are eligible for CalFresh enrolled into the program. Within the immigrant community, many are concerned about CalFresh and the public charge, as you may have seen or heard stories about this. But let me be clear, public charge does not affect all immigrants. Refugees, asylees, survivors of trafficking, domestic violence, and other humanitarian immigrants are not affected. If you are unsure about your circumstances, you can contact your immigration attorney or the Office of Immigrant Affairs at 1-800-593-8222 or visit oia.lacounty.gov to be connected to a free or low-cost immigration attorney. Other food programs like WIC or Meals for Seniors and Students are not considered a public charge. Please visit the county's food resources website at covid19.lacounty.gov/food to learn more about the variety of food resources available to LA County residents. The county will continue to expand its food assistance programs this fall, starting with increasing the number of food distribution events held in partnership with the LA Regional Food Bank for 2 to 3 each week. Additionally, the county is using the USC's studies findings to inform the development of a COVID food assistance grant program, which will fund community organizations that are providing additional forms of food assistance to people in need affected by the pandemic. Details on the program will be available soon. You know, throughout the pandemic, child care programs have remained open and serving families. Currently, over 4,000 licensed child care programs are open in LA County. Child care is the backbone of our economy, and parents seeking child care are facing financial hardships as the economy starts to recover. On July 21st, the LA County Board of Supervisors approved $15 million of CARES Act funding for child care vouchers to serve several essential workers and low-income families. This funding will provide 5,000 low-income families and essential workers with child care through December 30th of 2020. I want to thank the LA County Department of Public Health's Office of Advancement of Early Care in Education and in partnership with the Child Alliance of Los Angeles, who is leading this effort. LA County has a strong system of agencies that can process applications for vouchers and connect families to child care. Eligible families must be either essential workers or low-income working families. Families who are eligible include parents who work in healthcare services, emergency services, food and agriculture, transportation, critical manufacturing, and a range of other essential services, and other low-income families working in the business sectors. Families seeking childcare may apply for a voucher by completing an online application at ccala.net. And for further information or assistance, you may call 888-922-CHILD, C-H-I-L-D, or 888-922-4453. Once the family completes the online application, it is automatically routed to a local partner agency for processing. Once approved, families will be able to use the voucher with any licensed child care program or trust line approved license exempt provider, family, friend, neighbor in LA County. And I want to thank the Department of Public Health for setting up this program along with our partner, the Child Care Alliance of Los Angeles. And to all the essential workers providing child care, we thank you. If you need child care, please consider this program. It was created to serve you. Thank you, and with that, we will now hear from Dr. Barbara Ferrer.
Thank you so much, Supervisor Solis and the entire Board of Supervisors. Your commitment to protecting the health of all residents across LA County, including those who are at greatest risk, has been an inspiration and a guiding force for all of us. And good afternoon, everyone. Thanks so much for joining us. Today I'm going to provide an update on the indicators that we're using to understand how well we do as a county to slow the spread of COVID-19. And what we know from our past experiences about the factors that influence the numbers of cases, hospitalizations, and deaths across both the entire population and among those groups that are disproportionately impacted by the virus. We have made a lot of progress reducing transmission in LA County since we experienced that surge in cases, hospitalizations, and deaths starting in mid-July. And as we consider our future reopenings, we're going to use the lessons we learned from our past and the community transmission indicators to guide decisions regarding reopening sectors and permitting additional activities. When we move forward on our recovery journey and additional sectors reopen, it will remain important to understand how increased intermingling among non-household members affects community transmission of this virus. And let's start with a review of our recovery metrics, which we follow every week to understand how we're slowing the spread of COVID-19. And as you can see from our first slide here, these are daily reported cases from April through this week. And you can see on here that our cases started dropping significantly from the beginning of August through the start of September, so that now we've been seeing below 1,000 cases per day. This is a similar number to what we saw, if you look on this table, in early May, and that was before we started our reopenings. We have seen, and you can see this sort of at the tail end of the trend line, a slight increase in cases recently, which we're watching closely, especially because these increases are happening after the Labor Day weekend. I'll take the next slide. This slide shows our percent of test positivity, or the percentage of tests that are done and come back positive. The test positivity rate is influenced by how much community transmission is happening and the availability of widespread testing. And you can see this clearly on this trend line. At the beginning of the pandemic, when we had very limited testing capacity, tests were prioritized only for those people who were sick, and our test positivity rate was super high. It was at 16%. Under the safer at home orders and increased test capacity, our test positivity rate dropped from mid-April through May. With reopenings, we saw increases through July in test positivity rates, and then as we reclosed sectors, more people took precautions. We doubled our testing capacity. We've seen that our test positivity rate has dropped again. And you can see that the test positivity rate has fallen significantly from an average about 8% in July, when we were peaking in terms of our case numbers, to about 3% in this early part of September. We'll take the next slide. We do continue to track the daily number of people with COVID-19 that are hospitalized, so we can understand the impact of COVID-19 on the healthcare system. Similar to the previous two charts, there has been a continued decline in the number of people hospitalized for COVID-19 since the end of July. We've been below 1,000 hospitalized patients for most of September, and recently LA County is averaging about 750 hospitalized patients per day. These numbers of daily hospitalizations are slightly lower than our numbers in early April, and they reflect in part better treatments that result in shorter lengths of hospital stays. Next slide. When we review the daily deaths from COVID-19, we're reminded that changes in the number of deaths typically lags behind changes that we see in our cases and hospitalization numbers. On this chart, you can see that the spike in cases we experienced in early July led to an extended increase in deaths from late July through much of August. And again, though we're very pleased to see that deaths are falling, we remain vigilant, knowing that if cases increase as a result of Labor Day activities, we may again see both more hospitalizations and, unfortunately, an increase in deaths in the coming weeks. Now I want to go to the next slide. Our recovery metrics help us understand how to best move forward on our recovery journey. And this recovery journey is in part dictated by the state's blueprint for a safer economy, which provides us with a tiered framework that places counties in one of 4 tiers, depending on 2 metrics that measure the level of community transmission. Options for sector reopenings and permitted activities are aligned with each tier. And as a reminder, this tier shows us that the metric thresholds that are set by the state are then used to determine when counties are able and eligible to move to a new tier. You can move up in tiers, which would indicate that you're reducing community transmission, but you also can move down in tiers if after you've seen a decline in community transmission, you actually start seeing another increase in community transmission. And although LA County currently remains in Tier 1 with widespread community disease transmission, the metrics posted by the state yesterday indicate that we've reduced community transmission enough to begin qualifying for a possible move to Tier 2. This data that's used to calculate the metric that you're seeing here, it represents case and test numbers from the week of September 6th through September 12th. So there's about a 10-day lag here. Our adjusted daily case rate for this period dropped to 7 new cases per 100,000 residents. And the test positivity percent also dropped to 2.8. So you can see we qualify now by meeting the metric in Tier 2 for our daily case rate and for Tier 3 for our positivity rate. But I want to note, if you look on the state's dashboard, you'll see that LA County remains in Tier 1. And this is because we cannot move to Tier 2 until we sustain these numbers that you're seeing here, or the numbers continue to decline, for at least 2 consecutive weeks. Unfortunately, we did see an increase in our cases last week. We had 4 days where we were above 1,000 cases each day. So we're not sure that we'll have another week where an adjusted daily case rate is at or below 7 new cases per 100,000 residents. But we are heartened that LA County has met the thresholds that allow us to see our progress and in the future move to Tier 2. We will continue to closely monitor our data so that we can understand how to best effectively continue to slow the spread of COVID-19. But we are paying attention to the impact of both the Labor Day holiday, the reopening of schools for high-needs students, and the reopening of hair salons for indoor operations. We will be working with the board in the upcoming days to make data-informed decisions about all of the permitted options while we're in Tier 1 for reopening other sectors, and that includes nail salons for indoor operations. I'm so grateful to everyone here in the county, our residents, our workers, and our businesses who have played their part in slowing the spread of COVID-19. I'll take the next slide. I do want to give you an update on highly impacted groups that continue to experience disproportionate case, hospitalization, and death rates. This graph shows over time COVID-19 cases by race and ethnicity. These trend lines do show us that our cases have been decreasing across all groups, and we're also happy to see that the gaps are starting to close. At the mid-July peak, average daily cases among Latino, Latina, Latinx residents, and that's the yellow line at the top, were at about 200 cases per 100,000 people. And this is 4 times higher than the rate for white residents, which you can see with the orange line, and that was at about 50 cases per 100,000 people. And it's 5 times higher than the rate for Asian residents at 37 cases per 100,000 people, which is the blue line. Cases among black residents, the green line, at 80 per 100,000 people over this time period, was also far higher than that for white and Asian residents. But as of September 13th, the case rate amongst Latino, Latina, Latinx residents, while still unfortunately consistently higher than all other groups, has decreased to 37 cases per 100,000 people. And this is now less than twice that of white residents, who have a rate of 22 cases per 100,000 people, compared to 4 times the rate when compared to white people back in July. The case rate amongst black residents is now the same as that for white residents at 22 cases per 100,000 people. The case rate amongst our Asian residents continues to be the lowest at about 10 per 100,000 people. We'll take the next slide. This slide shows the average daily hospitalizations per 100,000 people by race and ethnicity. And we see similar significant declines across all groups, and also a closing of the gap between Latinx and the Black rate when compared to the rates for the other two groups. During the mid-July spike, which you can see clearly here, hospitalizations per 100,000 Latinx people were over 3 times greater than the rate for white residents, and the daily hospitalization rate among Black residents was double that when compared to white residents. But as of September 12th, hospitalizations among Latinx were 6 per 100,000 people. This has now dropped to 2 times the rate for white residents, who had hospitalization rate of 3 hospitalizations per 100,000 people. Hospitalizations among Black residents dropped to 5 per 100,000 people. Asian residents have the lowest hospitalization rate at 1.7 per 100,000 people. While inequities persist, the gap between Latinx residents, Black residents, and other groups here too is narrowing. While the number of deaths that we've seen from COVID-19 across our county is devastating, we are, as you can see on this slide, fortunately seeing decreases in deaths across all race and ethnicity groups. During the July peak, the mortality rate amongst Latino, Latina, Latinx residents was 6 deaths per 100,000 people. This is 4 times the rate that was experienced at that time by white residents, who had a mortality rate of 1.5 deaths per 100,000 people. The mortality rate amongst Black residents in July was 4 deaths per 100,000, and the mortality rate amongst Asian residents was 2.7 deaths per 100,000 residents. As of September 13th, the mortality rate amongst Latinx residents decreased to 2 deaths per 100,000 people. It's now twice that of white residents and Asian residents, both who have a mortality rate of slightly less than 1 per 100,000. Similarly, the mortality rate amongst Black residents decreased to a little over 1 per 100,000 residents. Last week, we had seen a slight increase in deaths among Black residents, and we're fortunate to be able to report today that the trend has started to decrease again. So it's devastating that the disproportionality continues to exist, and it has devastating impacts among communities of color. Nonetheless, I want to thank everyone who's worked really hard to address the disproportionality by really extending our ability to provide both needed services and to make some policy changes so that workers are protected and families have what they need to be able to promote their health and the well-being of all of their community members because they have access to the needed services, including quarantine and isolation support, and they feel that there is better access to testing and health care. So I want to thank everyone. Lots of people working hard to get this gap to narrow. The next, I'll take the next slide. We do also, however, look at cases and deaths by area poverty levels, and we see that area income has a direct correlation to the number of cases. Cases per 100,000 people in areas with the most resources and the lowest levels of poverty are far lower and have been for the entire pandemic than those in areas and communities that have higher rates of poverty and the least number of resources. While we do continue, again, to see decreases across all of our communities, the gaps are not closing here in a similar manner as when we looked at case rates by race and ethnicity. At the July peak, cases among people living in areas with the highest poverty rates, that's the orange line at the top, were 350 cases per 100,000 people, and that was over twice the rate of people living in areas with lowest poverty levels, the blue line at the bottom, who peaked at 146 cases per 100,000 people. As of September 13th, cases amongst people living in areas with the highest poverty levels is 78 cases per 100,000 people, and this is double that of the case rate for people living in the areas with the most resources, although we did close the gap slightly between the communities with the highest rates of poverty and the communities with the lowest rates of poverty. We also, and I'll take the next slide, we also continue to see higher mortality rates among people living in areas with fewer resources, even while all groups are seeing the decreases. The gap between people in the areas with the most resources and with the fewest resources has not significantly declined. During the peak, the mortality rate amongst people living in areas with the fewest resources was 6.5 deaths per 100,000 people, and that was over 3 times the rate for people living in the high resource areas. As of September 13th, the mortality rate amongst people living in areas with the fewest resources was 3.2 deaths per 100,000 people, which remains more than 3 times the rate of people living in the highest resource areas. So what are we doing to continue to close the gaps? And I want to say, again, thank you to everybody who's been working hard in this, sort of effort to eliminate the disproportionality. And we're sorry that we have not made the progress we had hoped we would see when we look at our rates among cases and deaths in those communities with high rates of poverty when compared to communities that have much lower rates of poverty. So there is still a lot of work that needs to be done to close the gaps. And this work remains, importantly, anchored in efforts to protect workers, particularly low-wage workers, who may, in fact, have started working when we were all safer at home, stayed working while we were all safer at home, in businesses that were not able to provide the appropriate modifications, mostly because at the time we didn't know how important it was for people to be masked and for people to be distant. Now we do know, though, and so our efforts really need to continue to be to protect workers, particularly those workers who go to work every single day, so the rest of us have all that we need to be able to go about our daily business. And that's where we're concentrating a lot of our efforts. I do want to note the improvements in having access to widespread testing, our partnerships with community-based organizations to make sure that everybody has the information they need to make good decisions, remains also anchored in an effort to close the gaps. And again, I thank all of our partners here. Now I want to update you on our, and you can see here where we've been successful and where we still have a lot of work to do. I want to update you on our current status. I am sad to report 31 additional deaths today. 10 of the people who passed away are over the age of 80, and 9 people who passed away in this age group had underlying health conditions. 14 people who died are between the ages of 65 and 79, and 10 people in this age group who passed away had underlying health conditions. 6 people who died are between the ages of 50 and 64, and 5 people had underlying health conditions. 1 person who died was between the ages of 30 and 49, and this person did not have underlying health conditions. This does unfortunately bring the total number of deaths in LA County to 6,423. We're thinking every day of the many people across the county who've lost a loved one or a friend to COVID-19, and we extend our sorrow and our condolences to everyone who's experienced a loss. 92% of the people who passed away from COVID-19 had underlying health conditions. This number has remained consistent across the pandemic, throughout the entire pandemic. Remind everybody, if you have an underlying health condition, it's important that you continue to stay home, away from other people as much as possible. For the 6,044 people who passed away where race and ethnicity has been identified, 51% are Latinx, 23% are white, 15% are Asian, 10% are Black, slightly less than 1% are Native Hawaiian or Pacific Islander, and 1% identified with another race or ethnicity. We are reporting today an additional 1,265 new cases, and this brings the total number of cases in LA County to 263,333. This does include 11,615 cases reported by the City of Long Beach and 2,536 cases reported by the City of Pasadena. We're also reporting a total of 1,742 confirmed cases amongst people experiencing homelessness. 779 confirmed cases are people who are currently hospitalized. 28% of the people who are hospitalized are in the ICU, and 16% of people who are hospitalized are on ventilators. We have investigated a total of 1,818 residential congregate settings and non-residential settings with at least one confirmed case of COVID-19. 452 institutional investigations are ongoing, but we have closed out 1,366 investigations. This does bring the total number of confirmed cases in institutional settings to 34,574, with 17,478 of the confirmed cases being among residents and 17,096 are among staff. We're sad to report that 2,795 residents who lived in institutional settings have passed away from COVID-19. 2,512 of the residents who passed away did reside in skilled nursing facilities. Of the 31 newly reported deaths today, excluding the deaths in Long Beach and Pasadena, 3 were deaths that were associated with people who lived at skilled nursing facilities. And again, we want to extend our thoughts and prayers with everyone who's lost someone they love to COVID-19. I'm reporting 3,693 confirmed cases at some point in the jail facilities. 3,265 were among people who are incarcerated, and 428 are among staff. There's 257 cases total at the state prison. 193 were among people who are incarcerated, and 64 are among staff. There are 758 cases in the federal prison facilities, 742 among people who are incarcerated, and 16 among staff. And we now have 151 cases at the juvenile facilities, 66 among youth, and 85 among staff. Over 2.5 million people here in LA County have been tested and had their results reported to us, and now the positivity rate is down to 9%. In closing, I want to leave you with a slide that sums up the impact of COVID-19 on mortality across the county. The green line at the very top of this chart shows mortality for 2020 by month from January through July. The blue line, by comparison, shows the average mortality for these very same months in the years 2017 through 2019. This gives us a sense of how many deaths we would have expected monthly for this year if we weren't living through the pandemic. The difference between the two numbers, the numbers on the blue line and the numbers on the green line, these are the numbers of deaths that we expected and the number of deaths that have occurred in 2020, is what we call excess mortality that we've experienced in 2020. And the gray bars that you see at the bottom show what we call a cumulative % increase above the expected number of deaths that occurred in 2020. And as you could see, as of July, we've experienced almost 18% more deaths than we expected due to the pandemic. In other words, when we compare the first 7 months of 2020 to the first 7 months of the past 3 years, we've observed on average 18% more deaths than we expected based on past trends. And we know that the excess deaths are not fully attributable to just people who died of COVID-19. But I do want to emphasize, especially for those who continue to believe that COVID-19 is no worse than a bad case of influenza, that this chart shows that in fact it's much worse, and that we've probably had 20 to 30% more deaths in May, June, and July of 2020 than we saw in the prior 3 years for the same months. And while the percent increases, they may sound small, if you look at the entire LA County population, this is translated into thousands of deaths that would otherwise have not occurred. For so many people, over 6,000 LA County residents, COVID-19 resulted in death, and for so many others, tens of thousands, it resulted in serious illness. All these people, they're our friends, our neighbors, our colleagues, and our loved ones. We can all commit to doing what we can using the tools we have to slow the spread of COVID-19. It saves lives, yours and other people in our community. And I say this often, but it's worth repeating. Please remember to keep your distance of at least 6 feet. Always wear a cloth face covering when you're out of your home and about other people. Wash or sanitize your hands often. Get tested if you're having symptoms of COVID-19. Isolate if you're positive for the virus, and quarantine if you've been a close contact for someone who's tested positive. And with that, we'll take questions.
Thank you. And our first question will come from Carolyn Shelby with LA Times. Please go ahead. Colleen?
Hi, thanks for taking my question. I wanted to know if you had a timeline for when the county will stop looking for Labor Day data related to case counts. And I was also wondering if the testing has continued to drop in LA County. I know that Dr. Gailey had previously said that there had been thousands of unfilled appointments. I'm wondering if that's still true, and if so, if the county is interpreting that as something of concern or as a positive sign that people are kind of heeding caution.
Yeah, thanks so much for the questions. I'll take the first question, then I'm going to ask Dr. Gailey to talk about the testing drop. We know now from past experience that we'll start seeing cases increase after an event or an opening, usually about 10 days after we've started with a reopening or there's been a large event. And then it sometimes takes another couple of weeks before we see the full impact. This is particularly true as we start looking at the impact on hospitalizations and then on deaths, because those even lag further behind. So right now, we want to wait and look at this full week of testing data so we see our new case data. And that will give us a pretty good idea. That's about 3 weeks worth of data. It'll give us a pretty good sense on whether or not we're going to see a significant increase in our cases associated with activities that may have happened over Labor Day. If we do see a significant increase in our numbers of new cases, we can be pretty certain that that will be followed shortly by some increases in hospitalizations, and then unfortunately usually follows that we see some increases in deaths. So this is a crucial week for us in terms of making sure that we're looking at our data around people who have tested positive. So thanks a lot, and I'll turn it over to Dr. Gailey for testing.
Hi, good afternoon. Yes, we still do have thousands of unused appointment slots at the county's operated testing sites, as well as I know at the city testing sites. We would very much encourage any LA County resident who has symptoms of COVID or who has an exposure to someone who has had COVID or even a suspected exposure to someone who has COVID to seek testing, in addition to testing among other populations like essential workers or people who live and work in high-risk settings such as congregate care facilities. There's a full set of guidance for requirements for testing and populations who would be prioritized for testing on the LA County DPH website, as well as on the state California Department of Public Health website. In terms of the level of concern, yes, we are concerned by that decline in testing. Testing is by no means the only way that we can combat COVID, but it is one very important part of the arsenal, combined with the compliance with other basic public health practices like washing your hands and wearing your mask, your face covering, and keeping your social physical distance. And we need people to continue to get testing if they do meet those criteria. It factors in, as you know, to the state's reopening plan and their tiered framework. So we would very much encourage people to get testing, know there's appointments available through the county or city operated testing sites, as well as at a variety of private partners, clinics, retail pharmacies, and many other locations. We'll take the next question.
Thank you. The next question will come from Patrick Healy from NBC. Please go ahead.
I'm sorry, hard time getting off speaker. Thank you for 3 questions, if I may. One, if Dr. Gailey could follow up you explained very well the reason why it's important for people to get tested, but could you hazard a theory why we are seeing this big decline in the number of people getting tests? Also, if you could comment on the increase in the R transmission number, it appears to be getting very close to the dangerous threshold of 1.0. And a question for Supervisor Solis, if she could talk a little bit about the timetable for consulting with public health on further reopenings and whether she expects the board will seek input from the affected sectors and industries. Thank you much.
Hi, I'll take the first two questions. Thank you for those. With respect to the reasons why people haven't been seeking testing at the same rate that they were earlier in July and August, I'm sure it's due to a variety of factors. So we do know that transmission has declined. I've reported out on the effective transmission rate in previous news conferences, and that number historically over the past few weeks had been down. So there were fewer people who were being exposed, potentially fewer people who had symptoms or thought they had an exposure. So that's probably part of it. But there's many other things that we know were happening at the same time. There were the wildfires, the poor air quality, people were being encouraged to stay within their homes. That probably contributed. We had a couple of weeks that were very hot. That probably also contributed to people's reluctance to venture outside and go get testing. And so again, whatever the reason was, and I'm sure there's many other reasons as well, please know that that testing is available and it is still an important thing that we need people to pursue. It's encouraging that the test positivity rate has continued to decline, as Dr. Ferrer just shared. But of course, test positivity is both reflective of what the overall actual positivity is within the community, the actual transmission, as well as the testing rate. So in order to see that test positivity rate get closer to what the true number is and continue to decline, we need the testing rate to stay high. On your second question for the R, last week I reported that the R was 0.95 with a confidence interval of 0.85 to 1.05. The R today, and the slides are located on the Department of Health Services website. Those were posted just a little bit ago. The R has increased to just above 1. It's being reported as 1.02 with a confidence interval of 0.95 to 1.09. So again, anytime that R ventures above 1, and this is now just above 1 at 1.02, it indicates that transmission is increasing over time. So again, please follow all those core public health practices. Please continue to remain home as much as possible and limit interactions with those outside your household. And that mask continues to be critically important. We'll take the third part of the question from Supervisor Solis. Thank you.
Thank you, Patrick, for the question. What I would say is that we regularly speak with our public health director, whether it's via email or phone conversations. We will be having our meeting this coming Tuesday, and we'll be able to discuss some of these items. And they're very, very, could I say, concerning because we know that we're waiting to see data coming back after the Labor Day weekend. So I'm very, very cautious of that. And just want to tell people, please continue to socially distance, make sure that you are wearing your mask and that you don't intermingle with other families that are not of the same household. Those are very, very important elements for all of us to consider. So let's stay steady and rely on the data as it comes forward. Thank you. Next question. One more question.
Okay, the last one will come from Claudia Pasuda from KNX News Radio. Please go ahead.
Thank you. I just wanted to note that on Monday, Barbara, you had talked about citations issued. The information suggested there are several gyms and churches that are repeat offenders. Excuse me, I'm still trying to get the names on that. Excuse me, I just choked. It's not COVID. Also, if we could get the deaths among homeless people, and here are my two real questions. You know, public health officials for years have been saying that safe-sex education works better than abstinence only. So I'm wondering, after so many months of telling people to stay away from anyone outside their household and all the evidence I see on social media that people are not heeding that warning, do you still think abstinence only is the way to go here, and if so, why? And then the second question is, based on comments and questions that I'm getting from people, I think many are having a hard time understanding if the big concern here is not overwhelming the healthcare system, why the county is holding off on reopenings given that hospitalizations are so low right now. Thank you.
Thanks a lot, Claudia. I think today you ought to see the names of any businesses or institutions where we've issued citations posted on our website. So hopefully that should be going up momentarily if it hasn't already. I think we're just figuring out how to get that onto the website, where it's going to be on the website. And then you should look for it getting updated on a weekly basis. In terms of the question of abstinence only, in terms of sort of how we describe what we're expecting people to do, I'm not sure that's really the right analogy because so many people are back at work, so many people have their children in childcare, so many people are really required through their daily activities, going through the grocery store, going to their physician, getting their medicines, going shopping. So many people are intermingling. So abstinence only to me is more like safer at home, when we really asked you to do absolutely nothing else unless you were an essential worker. So I don't know that that's the right analogy. I think what we are doing now is like harm reduction. Like, please, there are some things that we all have to do now, or we all really need to do in terms of working, caring for children, getting our groceries. But there's a whole host of other activities that are really not in that same group. They're really not as essential. And it's those non-essential activities that we've asked people to please not engage in. People are going back to their houses of worship. I mean, there is just a lot of opportunity for us to be with others. So not sure I think of it as abstinence only, what we're asking people to do. I think we're asking people to make sensible decisions given that we're living in a pandemic and we're all trying to get community transmission rates as low as possible. Intermingling with lots of different people is bound to increase the transmission of COVID-19. And I do like your question a lot about, we have low rates of hospitalization, so why are we so worried? I think we're so worried because we saw what happened in July, where we had relatively low rates of hospitalizations, and within a matter of weeks, we were seeing 2,200 people in the hospital, so every day. So it's very easy if we have increased transmission for that to very quickly result in increases in hospitalizations, which then, as we saw, resulted in increases in deaths. So I think we aim to have hospitalizations stay low, especially as we go into flu season, because we'll need to make sure we have capacity to treat and care for people who have influenza. So I think it's good explaining that when the hospitalizations stay low, it's not necessarily the time to say we should just do whatever we need to do at this point, reopen whatever makes sense from our perspectives as wanting to do more things, get more people back to work, without applying us the same level of caution that we've been applying the last few weeks. I think we learned a lot from what we all lived through in July and early August. But thanks a lot. And we'll now have remarks from Supervisor Solis in Spanish.
Buenas tardes y gracias por estar aquí hoy día con nosotros en esta conferencia de prensa. Hoy quiero hablar sobre dos cosas que han sido esenciales para nuestras comunidades, pero que también ha sido difícil de conseguir. Primero, hay un nuevo estudio que analiza el impacto de la pandemia COVID-19 sobre la falta de comida en el condado de Los Ángeles. Este estudio es el primero de su clase. La doctora Kayla Day-Hay, profesora asociada de Medicina Preventiva de USC, supervisó este estudio. La investigación de USC identificó varios datos importantes. Durante los primeros 4 meses de la pandemia, 1 de cada 4 hogares en el condado de Los Ángeles tuvo una falta de comida. Se estima que 873,000 hogares fueron impactados. La mayoría de los adultos sin suficiente comida entre los meses de abril y julio son de bajos recursos, mujeres, latinos, africanoamericanos y de 18 a 40 años de edad. Los principales factores de riesgo incluyen ser una familia de bajos recursos, estar sin trabajo y ser un padre soltero. El número de familias con acceso a comida ha subido. Subieron en abril hasta mayo de este año con unos 26% y bajó al 10% en junio y julio. Sin embargo, el número sigue siendo más alto del nivel antes de la crisis y eso nos preocupa. Las familias de bajo ingreso y las comunidades de color, que son las más afectadas por la pandemia, son también las que más sufren por la falta de comida. La falta de comida afecta la dieta de las personas y en este estudio se ve que las personas sufren por la falta de comida durante la pandemia tuvieron cambios no saludables en su dieta. Esto va a aumentar las disparidades en salud. Este estudio nos dice también que los programas que ofrecen fondos para ayudar a la gente están apoyando a muchas familias. Hemos iniciado muchos programas para evitar que la gente tenga hambre durante la pandemia y eso también está ayudando. Por ejemplo, el programa del condado de nutrición para los de tercera edad ha aumentado al doble el número de comidas que se ofrece. La participación en CalFresh también subió. El estudio encontró que entre los hogares sin comida al inicio de la pandemia tenían más comida en julio que los que no participaron en CalFresh. Algunos de la comunidad inmigrante piensan que pedir ayuda por CalFresh se va a considerar una carga pública. Voy a decir muy claramente que la carga pública no afecta a todos los inmigrantes. Sobrevivientes de tráfico y de violencia doméstica y otros inmigrantes no son afectados. Para más información pueden llamar a 211. El condado va a seguir ofreciendo comida gratis por entregas con el Banco Regional de Alimentos de Los Angeles Regional Food Bank, cada semana. Además, el condado va a apoyar organizaciones comunitarias que están ofreciendo comida gratis a las personas impactadas por la pandemia. Durante la pandemia, programas de cuidado de niños han estado abiertos. El 21 de julio, la Junta de Supervisores del Condado de Los Ángeles aprobó 15 millones de fondos de la Ley CARES Act para el cuidado de niños. Estos fondos estarán disponibles a forma de cupón para ayudar a 5,000 familias de bajos recursos y trabajadores esenciales hasta el 30 de diciembre en este año. Las familias que son elegibles incluyen a los padres que trabajan en los servicios de atención de salud, servicios de emergencia, transporte y otros trabajos esenciales. Las familias que buscan cuidado infantil pueden solicitar un cupón por completar una aplicación en línea que se encuentra en ccala.net. Para obtener más ayuda puede llamar usted a 888-922-4453. Quiero agradecer al Departamento de Salud Pública por establecer este programa junto con la Alianza de Cuidado de los Niños de Los Ángeles. Y le doy las gracias a los trabajadores esenciales que cuidan a los niños. Con esto me da bastante gusto presentar Jacqueline Valenzuela, que les va a hablar con más información. Gracias.
Buenas tardes. Hoy vamos a proveer una actualización sobre los datos que se utilizan para comprender qué también estamos frenando la propagación y qué sabemos de nuestras experiencias pasadas sobre los factores que influyen en el número de casos,